Have you ever noticed that the bicarbonate on the arterial blood gas is different from the bicarbonate reported in the serum electrolytes? Which one should you trust? Can this difference actually help diagnose laboratory errors or hidden acid-base disorders? In today's video, we'll understand the difference between measured bicarbonate and calculated bicarbonate, why they differ, and how to use this knowledge in day-to-day clinical practice. Let's begin. Many clinicians assume bicarbonate is measured directly in both ABG and the chemistry panel. Actually, only one is directly measured. Measured bicarbonate, or total CO2. This is obtained from the serum biochemistry analyzer. The analyzer directly measures total carbon dioxide, which consists mainly of about 95% bicarbonate, small amount of dissolved CO2, carbonic acid, and carbonate ions. Because bicarbonate makes up almost all of total CO2, laboratories report total CO2 as serum bicarbonate. So this value is actually measured, not calculated. While on an arterial blood gas, bicarbonate is not measured directly. Instead, it is calculated using measured pH and measured CO2 through the Henderson-Hasselbalch equation. Therefore, the ABG bicarbonate is a derived value dependent on the accuracy of pH and CO2 measurements. In most patients, the two values differ by less than 2 millimole per liter. For example, serum bicarbonate 24 millimole per liter and ABG bicarbonate 23 millimole per liter. This small variation is completely normal because different instruments are used, analytical variation exists, serum total CO2 includes dissolved CO2, calculations involve rounding errors. Clinically, these small differences are insignificant. When the difference becomes greater than 2 to 4 millimole per liter, stop and think. A large discrepancy between two values may indicate: Number 1. Laboratory error. Examples include delayed ABG analysis, air bubbles in the syringe, improper sample handling, analyzer calibration problems. Always repeat the sample if the numbers don't fit the clinical picture. Number 2. Sampling from different times. If serum electrolytes were drawn several hours before the ABG, the patient's acid-base status may have changed. For example, septic shock, diabetic ketoacidosis, cardiac arrest, and massive transfusion can rapidly alter bicarbonate levels. Number 3. Severe hyperlipidemia or paraproteinemia. Rarely, serum chemistry analyzers may report falsely low bicarbonate because of analytical interference in these situations. The ABG bicarbonate may actually be closer to the patient's true acid-base status. Number 4. Instrument-related differences. Remember, ABG machines and chemistry analyzers use completely different technologies. Occasionally, one analyzer may be inaccurate even though the other is functioning normally. Let's take a case. The patient with septic shock has pH 7.25, CO2 25 millimeters of mercury, calculated bicarbonate 11 millimole per liter. Serum chemistry. Measured bicarbonate 19 millimole per liter. This is an 8 millimole per liter difference. Immediately ask yourself, were both samples collected simultaneously? Was there an ABG sampling error? Is there analyzer malfunction? Has the patient's condition changed rapidly? Instead of blindly accepting one value, investigate the discrepancy. The mismatch itself is a valuable clinical clue. Serum bicarbonate is measured. It is derived from measured total CO2. ABG bicarbonate is calculated. It depends entirely on measured pH and partial pressure of arterial CO2. A difference of up to about 2 millimole per liter is usually normal. A larger difference should trigger evaluation for laboratory error, timing difference, sample handling problems, analyzer interference, and rapid change in clinical condition. Never interpret bicarbonate in isolation. Always correlate it with pH, CO2, electrolytes, anion gap, delta gap, and clinical presentation. Understanding the difference between measured and calculated bicarbonate makes your acid-base interpretation far more reliable and helps you identify laboratory pitfalls before they mislead clinical decisions. In the next video, we'll discuss another interesting topic in acid-base physiology. If you found this video helpful, don't forget to like, subscribe, and share it with your colleagues. Thank you for watching.